Hello, everyone, and welcome to the Melanoma Research Foundation's Ask the Expert series. My name is Miriam Kadosh, and I am the Director of Education and Patient Engagement here at the Melanoma Research Foundation. We are pleased to have you join us this evening for this wonderful educational opportunity entitled ASCO 2025 Highlights: What Cutaneous Melanoma Patients Need to Know. Today, we will hear from Dr. Katy Tsai, who will break down the most important melanoma research takeaways from this year's 2025 American Society of Clinical Oncology annual meeting, the world's largest cancer research conference. We hope that by sharing this information, it is a peek into the melanoma research space and what strategies researchers are working on to fight melanoma. Before we get started, I just want to share a little bit about the MRF. The Melanoma Research Foundation is the largest independent organization devoted to melanoma. Our mission is to eradicate melanoma by accelerating medical research while educating and advocating for the melanoma community. The MRF is committed to the support of medical research to develop effective treatments and eventually a cure for melanoma. We know that education is critical for patients to make informed decisions about their care. We have many educational programs and offerings, and they're not only directed at patients, but we create education materials and events for caregivers, family members, and providers. And I'm going to share a little bit about those tonight. Our educational literature is free to download on our website or to order for free for print. You can order for health fairs, schools, conferences, doctors' offices. We send these all over the US. We have 6 animated patient videos and 3 more currently in production. These are all less than 10 minutes long, packed with a lot of information and great visual images. If you have family or friends who want to learn more about melanoma, these are great educational options to send to them. Each year, the MRF hosts a series of in-person educational events in partnerships with major academic medical centers across the country. These meetings provide an opportunity to learn from leaders in melanoma and network with other patients and caregivers. We just completed 4 symposia, and you can go back and watch them at any time. You can find those links under the Events tab on our website or on our YouTube channel. We have 2 more that we're hosting in the fall, so if you live near Santa Monica, California, or Houston, Texas, please keep an eye out for more information on those soon. Not only are our past symposia available on our YouTube channel, but we have dozens of other educational offerings available. So this is what our YouTube site looks like. We have our Ask the Expert webinars there and melanoma educator courses. We have a variety of patient and caregiver support services that you can check out, such as our patient and community forum, our treatment center finder, a financial assistance resources, our Ask a Nurse hotline and email, and we have a clinical trial finder. So if you are looking for a clinical trial or interested in learning more about clinical trials, we're proud to partner with CareBox for our clinical trial finder. It will connect patients with trials tailored to their specific diagnosis, ensuring that they receive most up-to-date care options available. You can also connect with a clinical trial navigator to help gather information regarding diagnosis, staging, and treatment history, provide information and contact details for trial matches, help overcome barriers to enrollment, provide basic education regarding clinical trials and the logistics, just to name a few. So you can find this information on our website underneath the Patient Care tab. I wanted to give a quick shout out to our newsletters to stay in touch and in the know with what's going on with us on a monthly basis. So if you scan this QR code on the screen with your cell phone, you can join our newsletters. We have a few different ones, so get on our website and check out which newsletter suits you. And we look forward to staying in touch. Lastly, there are many opportunities to support the work of the MRF through a variety of programs, events, and research funding. Feel free to contact me or anyone at the MRF after this webinar to talk to us about ways you can engage in the melanoma community while investing in our shared mission. The best way to learn more about the MRF, including information about education, advocacy, and our research programs, is to follow us on social media. You can hear all about our awareness campaigns and any upcoming events as well. A bit of housekeeping before we get started. We encourage you to use the Q&A box to ask questions throughout the session. And thank you to many of you who have already sent in questions during your registration process. The information presented today during the session is for educational purposes, and any individual treatment questions should be directed to your healthcare provider. We encourage everyone to visit melanoma.org to learn more about the resources that we do have available. And please do fill out the survey in the future. Please do stick around for the end because we will have a Q&A session as well. Okay, now I'd like to introduce our expert this evening. Hope everyone can hear me okay. Tonight, we will hear from Dr. Katy Tsai. Dr. Katy Tsai is an associate professor in the Division of Hematology Oncology, Department of Medicine at the University of California, San Francisco. She is a medical oncologist specializing in the treatment of patients with melanoma and other skin cancers, and a clinical researcher whose goals are to find effective treatment and monitoring strategies for these patients. She serves as medical director for the Melanoma and Skin Cancer Program at UCSF, vice chair for the Clinical Trial Site Committee, and co-director for the UCSF Cancer Immunotherapy Toxicity Evaluation Program. I will turn it over to Dr. Tsai to share with us this evening.
Hi, good evening, or maybe I should say good afternoon from over on the West Coast from San Francisco. Thank you so much, Miriam, for your very kind introduction. And I wanted to thank the MRF, as well as all of you in attendance on the webinar today for taking some time out of your very, very busy lives to join us this evening. So I'm going to go ahead and share my screen. And Miriam, feel free to let me know just to confirm that I'm sharing the right screen and that you can hear me well.
Perfect.
Great. So welcome to this webinar, ASCO 2025 Highlights, What Cutaneous Melanoma Patients Need to Know. For those of you who may not be familiar with ASCO, this is one of our largest professional societies within oncology, otherwise known as the American Society of Clinical Oncology. This is a very large conference that for the last many years has been held in Chicago, and it really has an international footprint. At this conference, typically things that are showcased are cutting edge research, data from important clinical trials that are felt to either inform practice or to be practice changing, and also to highlight emerging trends in this space. I think sometimes what some of my patients may also not necessarily be aware of is that these are also important education sessions for your doctors. Often there are many education sessions held. It's also an opportunity for not only doctors, but other healthcare providers to network with each other, find out what's new, and to discuss cancer-related topics, not necessarily directly related to treatment, but things that may touch on health policy, quality improvement, or cancer survivorship as well. So ASCO this year was held from May 30th to June 3rd. and what can I tell you about what we found out about melanoma? So in the next 35 minutes or so, it's going to be a little bit of a whirlwind, but hopefully this will give you some food for thought. And what I'll be going over in the next half hour or so are the following. So updates in adjuvant therapy and also in neoadjuvant therapy, updates in treatment of metastatic or unresectable melanoma, and also to highlight some emerging studies in the melanoma oncology space. For those of you who may need a bit of a refresher on what these terms mean, just a reminder that adjuvant therapy in our world refers to drug given as prevention. So drug given to prevent high-risk melanoma from coming back. Neoadjuvant therapy refers to drug given before surgery in an effort to shrink the melanoma tumors and to improve short-term and long-term response. Metastatic treatment, as I mentioned earlier, refers to melanoma that has spread to other areas of the body such that it's considered unresectable or not easily removed by surgery. And then, as I mentioned earlier, emerging studies, hopefully we'll have time at the end to highlight some things that may not be ready for prime time, but which I think would be of interest to all of you. So the following slides, I think, will assume some baseline knowledge of these drugs, which I've listed here below. This is a very kind of broad overview of things that I consider within my toolkit of drugs to reach for. I am a melanoma oncologist, so not a surgeon or a radiation oncologist. So just a reminder that as far as immune checkpoint inhibitors, these are immunotherapies given intravenously that work to release the brakes on your immune system. And what I mean by that is your body's immune system has certain mechanisms in place to try to restrict inflammation. Sometimes that cannot be the desired outcome when we're trying to unleash our immune system to recognize and fight cancer. So these immune checkpoint inhibitors, or ICIs, target certain receptors that help to keep your immune system cells activated and ready to inflame and kill off the melanoma. For BRAF-MEK inhibitors, the way that I like to describe these to my patients is that for melanomas, and specifically melanomas that start on the skin, about 30–40% of these patients will have melanomas that have a mutation in a gene called BRAF. What this mutation does is that it causes a growth switch in the melanoma to get stuck in the on position, if you will. So it grows, 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 doesn't know how to stop. And as it turns out, due to past research and large clinical trials, there are BRAF inhibitors that work to turn that growth switch off. And those BRAF inhibitors work best and have fewer side effects when we combine them with something else that stops that growth signaling pathway called MEK inhibitors. Last but certainly not least, there are many other immunotherapy-based treatments out there. So I just wanted to mention that lifileucel is an adoptive cell therapy that has been approved for melanoma within the past year. T-VEC is another type of immunotherapy called an oncolytic virus therapy that is injected directly into tumors, which is also FDA approved. So without further ado, moving on to the section for updates in adjuvant therapy. So why give adjuvant immunotherapy in the first place? Well, as I mentioned earlier, and as you can see from this cartoon, the premise is that, yes, a surgeon can remove a melanoma tumor, but the concern is that especially for higher risk melanomas, for example, thicker melanomas or melanomas that we know may already have traveled to the lymphatic system, that the concern is that there are melanoma cells left behind, which left to their own devices could grow and cause problems later. So the goal of giving immunotherapy after surgery is so that the immunotherapy can activate the immune system, the T cells, which recognize and fight cancer, so that they can clean up, if you will, any residual melanoma cells left behind. The current standard of care for adjuvant immunotherapy consists of PD-1 antibodies. In other words, these two drugs, pembrolizumab and nivolumab, which work to target the PD-1 receptor. The reason these are considered standard of care is based on these two large phase 3 clinical trials highlighted here on the right, Checkmate 238 and Keynote 054. What these two charts are describing is something called relapse-free survival. Relapse-free survival, I would define as the length of time after treatment during which someone stays free from the cancer coming back. So in an ideal perfect world, right, it would be nice to see this line staying at 100%, right? You would want to see 100% of patients staying disease-free this many months out from the end of treatment. And on the x-axis, you can see here is time in months. On the y-axis, the percentage of patients. So Checkmate 238 was a study which randomized patients with resected melanoma to either nivolumab or ipilimumab, which is a different immunotherapy targeting a receptor called CTLA-4. Keynote 054 enrolled a similar population, meaning patients who had had their melanoma resected but at high risk of recurrence. And these patients were randomized to either receive pembrolizumab or placebo. And in both charts here, I'll just highlight that the investigational arm, which was nivolumab in the upper chart and on the bottom chart, the pembrolizumab, that you see that the recurrence-free survival is better in that top line than the comparison arm, which is on the bottom. So this is the data that led to the approval of pembrolizumab and nivolumab as adjuvant therapy. The question has arisen over the years of whether or not we can do better than just this one drug. We improve our clinical outcomes even more. So at ASCO, there was a study presented called Relativity 098. And what this study did was take, again, a similar population, high-risk stage 3 to 4 patients who had had their melanomas resected, and randomize them to either get a combination treatment of nivolumab plus relatlimab, which again is a different immune checkpoint inhibitor targeting a cell receptor called LAG3. So they randomized patients to either get this combination versus a standard of care, or in this case, nivolumab monotherapy. And then they followed these patients out. Some of the endpoints of interest that were measured at the end were recurrence-free survival, which I had talked about on the previous slide. So what did those results show? So hopefully at first glance, you can appreciate that the lines here look pretty different from the lines I showed you earlier. So this again is relapse-free survival, percentage of patients on the y-axis and time in months on the x-axis. And while it would have been really heartening to see the combination Nivo-Rela arm show improved recurrence-free survival, you can see that here, that is not the case, that the recurrence-free survival is basically very similar to the RFS that we see with nivolumab. So this actually was a negative study. And I think what this highlights is that we really need to rethink the role of combination immunotherapy in the adjuvant setting. I'll come back to that later. But in terms of other updates in the adjuvant space from ASCO this past year, also wanted to highlight another study. Just for a quick bit of background, some of you may already know that BRAF-MEK inhibitors also actually are an approved adjuvant option for patients whose melanomas have a BRAF mutation. The rationale for that, or the trial that led to the approval of using dabrafenib plus trametinib in the adjuvant space, came from this trial called COMBI-AD. Again, this is RFS, or relapse-free survival. You can see that patients who received dabrafenib trametinib, as indicated in the yellow line, had better RFS compared to patients who received the comparison drug, which actually in this case was placebo. So not only that, but thinking about trying to improve outcomes for our patients, over the past few years, what's happened is that adjuvant therapy has actually moved into earlier and earlier stages of melanoma. What we know actually is that stage 2B and C melanoma, even though there is no lymphatic involvement, that these melanomas, because they're thicker, are actually at higher risk of recurrence as well. these two studies, Keynote 716 and Checkmate 76K, so these were two studies done in a stage 2B and stage 2C resected melanoma population that showed a benefit for giving pembrolizumab or nivolumab in the adjuvant setting. So then investigators asked the question, is there a role for adjuvant BRAF-MEK inhibitors for stage 2B and C melanoma? This question previously had not been looked at, but this trial called Columbus AD was launched and outcomes were reported at ASCO this past year. The way the study was designed was that, again, patients with stage 2B and 2C melanomas that had been surgically removed were randomized to either get encorafenib plus binimetinib, so these are BRAF-MEK inhibitors, versus a control arm in which patients received placebo. I think it's important to acknowledge that we design studies assuming that we'll have certain power, which often involves being able to enroll enough people to make sure that we have good data and sufficient data to be able to measure what we want to measure. I think the investigators for this study very rightly pointed out that unfortunately recruitment was a problem for this trial. In black, you can see that this indicates the number of patients who were randomized. In red, you can see that that was their target accrual, which unfortunately was not reached. That being said, is there anything we can learn about this study? So, again, with the caveat that not a full number of patients were enrolled, I would say that the recurrence-free survival in this case was encouraging. You can see that the yellow line, which indicates the patients who received adjuvant encorafenib plus binimetinib, at 12 months did have improved RFS compared to the patients who received placebo. So putting all of this together, what can we say about at the stage of adjuvant therapy for melanoma? So number one, I would say that while both of these studies had their downsides, on one hand, that first trial I mentioned was a negative study. The second study we reviewed didn't meet its accrual goal. So I would say that there's definitely nothing practice changing here. But I think it's important to point out that all of this data does affirm to us that adjuvant immunotherapy with PD-1 monotherapy, either pembrolizumab or nivolumab, remains the standard of care. I think that the role of combination immunotherapy in the neoadjuvant or metastatic settings remains arguably a standard of care and remains promising, but certainly not in the adjuvant space. Regarding the role of BRAF and MEK inhibitors in stage 2B and C resected melanoma, I think it's just really hard to draw conclusions about this. These are encouraging results, but certainly not strong enough for FDA approval. So let's move on to neoadjuvant therapy. As a reminder, we had talked earlier about the rationale for adjuvant immunotherapy. So what's the grounds for giving this in the neoadjuvant setting or preoperatively? So as you can see from this cartoon, here in this case, before surgical resection, immunotherapy is given. The hypothesis is that giving this before surgery, when there are more tumor antigens or proteins in place for the immunotherapy to help your immune cells recognize, is that it results in more T cell diversity. In other words, it is helping your immune system be able to recognize a higher number of melanoma proteins, which we hope will help the immunotherapy be more effective in the longer term. So you can see on this bottom cartoon here, the much higher number of T cells that seem activated compared to when we give it in the adjuvant setting only. So last year at ASCO, there was a pretty high profile study called the NADINA study, which utilized neoadjuvant combination immunotherapy with ipilimumab plus nivolumab. This was following on the heels of another adjuvant study called SWOG 1801, which used pembrolizumab alone in the neoadjuvant and adjuvant setting. So I won't spend too much time on the details here, but hopefully looking at these two charts of event-free survival, You can see here that the blue arm, which indicates the neoadjuvantly treated patients in both charts, that the event-free survival was better in the group of patients who received neoadjuvant therapy compared to those who received adjuvant alone. And just a note that in this case, event-free survival refers to kind of a composite endpoint, basically patients who experienced any number of adverse events, prior to going to surgery. Either disease progression, side effects from the neoadjuvant therapy, those are some of the things that factored into event-free survival. So again, wonderful that we have this baseline of having two important trials be able to guide us in what should commonly be used as neoadjuvant treatment. But again, can we do better? So I think, why do this in the first place, right? Why do neoadjuvant therapy? I think sometimes when I talk about this to some patients, there's a little bit of hesitation, right? If something is surgically removable, why not go ahead and do it? So I think, hopefully this slide will get at one of the answers to that question. So the International Neoadjuvant Melanoma Consortium was able to show across many different small neoadjuvant trials that actually once that melanoma tumor is removed after a few doses of immunotherapy, what they've been able to show is that the degree of pathologic response in that tumor sample actually is predictive of clinical benefit. You can see here, so this again is that metric RFS, and this is looking at RFS divided by the degree of pathologic response. So if we just look at the blue and yellow arms up top, which as you can see on the right reference basically a pathologic complete response or near complete response, meaning very little to zero melanoma left in that sample, that they have better RFS compared to those who have more tumor left behind. So I know that seems a little bit maybe self-evident, but I think it was very important data to establish at baseline going into neoadjuvant trial design. So what did we learn from ASCO 2025? So this was the CITE NEO trial, which was presented by colleagues at Memorial Sloan Kettering. You can see here that the proposed neoadjuvant regimen is not new. In fact, it uses the same drugs as NADINA trial used, but at slightly different doses. So NADINA used lower dose ipilimumab and higher dose nivolumab. In this case, it's flipped such that ipi is given at higher dose and nivolumab is given at the lower dose. But I think one of the novel things about this trial was the number of doses that patients received in the neoadjuvant setting. They only received one dose, compared to the several doses that were given in NADINA and SWOG 1801. So what did this trial show? So in terms of looking at the pathologic response after surgery, you'll notice that this number is quite high, up to 59%. I'll show you a more comprehensive table in a second, but this is very similar to the degree of pathologic response that was achieved in the NADINA trial, but this time with only one dose of ipi-nivo. And this is just some preliminary data from that group showing that it does correlate very nicely with good RFS, albeit at an early time point of 12 months of follow-up. So let's come back to that. But I also did want to highlight another neoadjuvant trial that was presented at ASCO 2025 called EA6194. So this was also a neoadjuvant trial design. And as you can see here, the two arms that patients could be randomized to were either standard of care, pembrolizumab at standard dosing, versus a novel immunotherapy agent called vidutolimod, which is actually given first subcutaneously as an injection under the skin, then followed by direct injection into accessible tumors in combination with pembrolizumab. The primary endpoint for this study was looking at the degree of pathologic complete response. And you can see here that the degree of pathologic response that was achieved in arm B, which is the investigational combination arm, was very high, exceeding what we saw earlier. This is sitting at 79% major pathologic response. On the right-hand side of the slide, you can see that, again, I'll highlight in red that with some limited amount of follow-up right now, that the combination treated patients have improved event-free survival compared to those who received pembrolizumab alone. So what can we say about the state of neoadjuvant therapy? Um, so I think from a very high level perspective, I would say that neoadjuvant therapy is here to stay. There's been a lot of data presented in our field over the past, several years that the clinical outcomes we see from neoadjuvant therapy, plus or minus some adjuvant therapy on the back end, that we're able to do better for our patients than when we give adjuvant therapy only after surgery. I know that this seems like a bit of a busy table, but let me just take you through it, hopefully for a few minutes here. So on the left-hand side of this table in dark blue, you can see that I've highlighted the two trials I discussed earlier, S1801 and ADINA, which have formed the foundation of what we consider potential standard regimens of neoadjuvant therapy. I didn't talk about the nivolumab plus relatlimab trial, but just did want to include that on this slide. It's a regimen that we know works in metastatic unresectable melanoma. So investigators at MD Anderson have looked at giving this in the neoadjuvant and adjuvant setting as well. And then in yellow, you can see that I've included the two neoadjuvant studies that I just discussed. So what can we learn from these studies when we put them side by side? So number one, with the CITE study, which used ipi-nivo, you can see that just with one dose of this combination, that there was a major pathologic response rate achieved that was similar to what we see with NADINA, and with a much lower toxicity rate. Grade 3 here refers to the severity of the side effect. That's usually graded from 1 to 4. Grade 3 usually means serious, meaning that it's enough to land someone in the hospital. So 9% versus 30% certainly is really intriguing, and I think demonstrates exactly why we need to move forward in this field with investigating alternative neoadjuvant regimens. How about in comparison with EA6194? So here, again, just highlighting that the major pathologic response rate that we saw with this intratumoral injection is higher at 79% than what we have seen historically. So again, food for thought in terms of how we can continue to push this field forward. Certainly a very exciting space. I could dedicate an entire talk probably to just talking about neoadjuvant therapy. Just for your information, I did want to include on this slide as well results from two other neoadjuvant studies that were also presented at ASCO this year. Certainly, things to bring up with your doctor, or if you have the time and the wherewithal to look these up yourself. Again, hopefully your doctor or your care team can help guide you through these results as well. You'll notice that in yellow and purple, these are all very, relatively smaller studies compared to SWOG 1801 or NADINA. So again, quickly evolving space, lots of ongoing trials looking at trying to determine the optimal neoadjuvant combination. So here are the takeaways. I think I've already mentioned again that while we have two commonly used neoadjuvant studies based on the largest trials to date, that the optimal neoadjuvant combination remains debatable, remains under investigation. And certainly if this is something that you or someone you know might benefit from, definitely I encourage you to discuss that with your care team to talk about the details of why one combination, not the other. Is there a room for clinical trial enrollment, etc.? So let's move on to metastatic therapy, and a reminder that this refers to treatment for unresectable metastatic melanoma. So at ASCO 2025, an update was provided on the DreamSeq study. I love that trial name. So results from the DreamSeq trial have been published before, but this was a 5-year update that I think was important for all of us to at least see today. So for a bit of background, for patients who have BRAF-mutant melanoma that is unresectable, it's been a historical point of debate as to whether patients do better, starting with immunotherapy-based treatment versus BRAF and a MEK inhibitor-based treatment. So this study was designed to exactly answer that question. It was looking at the efficacy and toxicity of the sequence of nivo-ipi, followed by dabrafenib trametinib, to the converse sequence. So maybe a little bit complicated, but you can see from this flowchart here that this study enrolled patients with BRAF-mutant metastatic melanoma. Following the top side of this flowchart, you can see that patients were randomized to either arm A or arm B. Patients randomized to arm A received IPI, the standard dosing of IPI plus nivo, followed by nivo monotherapy maintenance. And then at the time of disease progression, they were moved to arm C, which was treatment with dabrafenib and trametinib. Arm B and arm D, as you can see, did the exact opposite sequence. So fair warning that the next 2 slides are a little bit dense, but let's walk each other through this. So a reminder that these are updated trial endpoints through 5 years. So what you can see here in red are the principal efficacy endpoints of the 2-year overall survival, which was one of their primary endpoints. And that, as you can see up top here, that patients who started with immunotherapy and then moved to targeted therapy, targeted BRAF therapy, had better 2-year overall survival at 68.3% compared to patients who did the opposite sequence here at 54.1%. This clinical benefit is echoed also in looking at the median progression-free or relapse-free survival, so the amount of time that patients really remained free from their melanoma, that this was a longer period of time in the arm A group compared to those in arm B. Moving to the next section down here, you can also see that it seems that those who were treated with immunotherapy first also had better duration of that response. So what did we learn from ASCO 2025? So shown in green here, you can see the updated 5-year overall survival data. Here, again, looking at this updated data, you can see that 5-year overall survival is improved in the arm A to C arm at 63.3% versus 33.9% in the arm B to D group. This clinical benefit also is seen in the progression-free survival, again, 39.4% in the arm A patients versus 12.8% in the arm B patients. Looking at this row here, so ORR refers to objective response rate, which refers to the percentage of patients that have objective or measurable shrinkage of their tumors. So you can see here in this case, actually, that the numbers show that this is equivalent in both arms. I think there's some nuance there, but I think certainly it's good to see that there's no one arm here that's clearly inferior to the other. And then looking at the duration of response, again, maybe not surprisingly given the data that we looked at earlier, that the arm A patients do continue to show better duration of response compared to those who were in arm B. So this is confirmation again that even for patients with advanced BRAF mutant melanoma, that they do better in terms of their clinical outcomes when starting with immunotherapy first. This year at ASCO, the investigators also provided an update looking at subsets of the patients who were treated. So in other words, looking at this data in aggregate, yes, it's wonderful that we can see this benefit overall. But if we look at these specific groups of patients, for example, their sex, their age, their performance status, which is PS, other clinical characteristics, is there one group that seems to do better or worse with one arm versus the other? So this is a forest plot here highlighting 4-year overall survival differences between these sequences. If you were to stand back and look at this from afar, you can see that dots and lines falling on the right-hand side of this dotted line indicate superiority of arm A, which was the immunotherapy first arm. And so you can see that this clinical benefit really seems to fall across these clinical subsets, that there's, in other words, there's no dots, so to speak, that you can see that are falling on the left side of this dotted line, which would indicate superiority of arm B. Important to realize, I think, that looking at certain subgroups that you might expect to do more poorly, for example, older age or higher LDH, that these patients still do benefit from starting off with the immunotherapy arm. I won't spend too much time on this slide since I think we already looked at the table earlier, which shows the duration of response. Here you can see on the left-hand side the older data where it reassuringly seemed like the arm A immunotherapy first group had better duration of response and continues to be reassuring in the sense that 3 years later that we're still seeing arm A outperform arm B. The other interesting analysis that was presented at ASCO, which is admittedly exploratory but thought-provoking, was looking at time for developing a metastasis, a distant metastasis, and not just any distant metastasis, but specifically in the brain. I think as as a clinical researcher and as someone who sees a lot of melanoma patients, that anecdotally it seems that yes, I'm so incredibly happy that we've gotten to the point in our science that we can help patients live longer. Maybe a little bit of a double-edged sword that sometimes when we are able to extend prognosis, that one important, I think, fallout of that is recognizing this concern for recurrence or what the probability of that happening. One site of recurrence that, of course, we worry about clinically is in the brain or the central nervous system or CNS. And so here they did an exploratory analysis looking at, did it matter which arm you were on in terms of risk for developing brain metastases? So again, maybe putting here, again, that little plug for immunotherapy first. You can see that here, the black line, which is the arm A immunotherapy first arm, that if someone was to develop CNS metastasis, that they had a prolonged time before they developed that site of disease compared to those who received the BRAF-MEK treatment first. Switching gears a little bit, so staying within the metastatic treatment category, but switching gears to ways in which we can improve efficacy and the safety profile of our regimens. I'd like to highlight one study looking at blocking a cytokine called IL-6. You can see here a cartoon basically describing how IL-6 or interleukin-6 signaling, this is a compound that is essential for certain immune cell interactions, which can trigger autoimmunity. So the hypothesis was, well, if we block this, if we block an IL-6 receptor, in this case using a drug called servillimab, is it possible that we could not only decrease the severity and frequency of side effects and also boost efficacy? So this, I thought, was a super interesting and well-done study led by Dr. Menard at NYU. So this was utilizing a pretty high-risk treatment regimen of triple therapy. So we've talked about IPI plus Nivo, but you can see here that this was a triplet regimen using IPI plus Nivo plus relatlimab. And some of these patients then also received the IL-6 receptor blocking antibody called servillimab. So what did this study show? Oh, and just a reminder that the endpoints of interest here were objective response rate. So in what percentage of patients did the tumors shrink? and also looking at the IRAE, or immune-related adverse event rate. So you can see here the clinical efficacy. On the left-hand slide, we call this a waterfall plot. This is tracking the change in the size of the tumors for each patient. Things that are above this line here indicate progression. Things that show the bars going in the opposite direction from 0 show shrinkage of these tumors. So just even off the bat, you can see that the number of responses in these patients was pretty impressive. We're seeing a lot of bars going in the negative direction. Over on the right-hand side, you can see this 24-week objective response rate. And you can see here that 21 or 63.6% of the patients enrolled in the study had shrinkage of these tumors. This is a relatively small study, but I think when you compare these objective response rates to other studies, namely Checkmate 511 was looking at a low-dose IPI plus Nivo combination. Relativity 048 was looking at nivolumab plus relatlimab. Yet seeing this number is incredibly reassuring and interesting that this response rate seems higher than what we've seen from other studies. So not only was that thought-provoking and impressive, but looking at the safety of this regimen also was quite interesting. So I'll just highlight or draw your attention to this box I've highlighted in red, which refers to the number of serious side effects out of this treated patient population, which is 12.1%. Again, if you look historically at this box here with the previous trials, 12.1% is quite low. There certainly were some severe side effects, but certainly not to the frequency that we would expect for a triplet regimen. And so super thought-provoking. The investigators are doing some ongoing work looking at how exactly this is working, or are there clues we can see looking at circulating biomarkers in the blood that might help us learn more about how and why this is working. So metastatic therapy takeaways. So here I would just highlight the 5-year update from DREAMseq that immunotherapy remains the preferred initial treatment for the vast majority of patients with treatment-naive BRAF-mutant metastatic melanoma. And also, as we just saw, that inhibition of IL-6 seems to be an interesting approach to improving efficacy and safety outcomes in this patient population. And I'll be interested to see how that evolves. I know that they're moving forward to a larger randomized study. So I know that we're getting a little bit short on time, and this is probably a little bit of a whirlwind. And I would like to leave enough time for questions. But I did want to just take a few minutes to highlight some emerging studies specifically in the adoptive cell therapy space. So what I mean by adoptive T-cell therapy is that this refers to a group of drugs where basically researchers and doctors can supercharge a patient's own T-cells to fight cancer. But they do this in different ways. So for example, with TIL therapy or tumor infiltrating lymphocyte therapy, basically this is the reason this is thought to work is that we are taking immune cells that are already fighting the tumor. And so if we can remove these from the tumor and give them a big boost and then give them back to the patient, that this can be a type of tumor-specific personalized cell therapy. This actually has been shown to be effective in melanoma. There is an FDA-approved product called lifileucel, which is now FDA approved. Definitely glad to have it available, but it is quite time and labor intensive, as you can see from this cartoon on the right-hand side. So how can we do better, or what else is out there? I'll highlight also CAR T-cell therapy and TCR, or T-cell receptor T therapy. In engineered TCR T-cell therapy, what's happening is that we're able to engineer T-cells to find cell targets that are actually hidden inside the cancer cells. So this is super exciting and novel. Maybe the caveat here is that So far, this has shown that it can be done only in patients who have the right genetic match. So patients do need a certain correct genetic or HLA match for the current iteration of these therapies to work. So still experimental, but promising. For time, I won't talk too much about CAR T therapy since so far it's shown to work best in blood cancers. I'm still certainly working on how best to make that effective for solid tumors. But while we're talking about TCR therapy, I wanted to highlight IMA203. So this is an engineered TCR T cell therapy. It's been engineered to recognize an intracellular peptide called PRAME. And this is presented by a certain HLA type, HLA0201, on the cell surface. IMA203 is this drug which can utilize this immune cell machinery to recognize a certain type of T cell receptor to help fight melanoma. At ASCO 2025, the company presented data from this trial here. I'm just going to speed through this. Basically, it involves leukapheresis, or removing white cells from a patient with the correct HLA type. It involves then giving chemotherapy to deplete existing immune cells, and then giving the cell product, and then giving additional therapy to help grow up those cells. Just skipping ahead, so we talked about waterfall plots before. So anything below this 0 line is looking at objective response or shrinkage of tumors. And again, hopefully standing even from 100 feet away, you can see that this looks incredibly promising, not only in cutaneous melanoma with a lot of these bars going in the negative direction, also in uveal melanoma. I know that the MRF is doing a separate section on promising agents in uveal melanoma, so I won't spend too much time here, except to say that I really look forward to what we see in the next phases of this trial. Last but not least, also at ASCO 2025, there was some really interesting data presented out of Dr. Jennifer McQuaid's group at MD Anderson, looking at the effects of high fiber on the effective immunotherapy. So again, in the interest of time, I won't spend too much time on this, but I thought that these results, even though it was examining only a relatively small group of patients, that it seemed like patients who were fed a high fiber diet compared to those who were fed a healthy control diet and the high fiber is the dark green, the controls are in the light green. You can see here from this waterfall plot that those who were fed a high fiber diet seem to have improved immune checkpoint inhibitor response compared to the healthy controls, and that this objective response did translate to improved event-free survival in the dark green line here on the right-hand side. So hopefully you're still with me. Trying to pull all of this together, I would say that first thing in the adjuvant space, anti-PD-1 monotherapy remains standard. I'll again highlight neoadjuvant therapy as a valuable platform to improve clinical outcomes and also for drug discovery. There are several regimens out there, but not a single one yet, or maybe we should keep some variety there to allow us to have that conversation with our patients about which one we think is most rational and would work the best for you. In the metastatic setting, first-line treatment of immunotherapy remains standard of care for the majority of patients, even if they do have a BRAF mutation in their melanoma. Some interesting data in our ability to prevent and to treat immune-related side effects, even in the metastatic setting. And last but not least, in terms of things you can take away, I would say that adoptive cell therapy, specifically with tumor-infiltrating lymphocyte therapy, is now a reality for solid cancers. We need to work on improving the logistics and operations of this to make it available for more patients at more centers. And last but not least, again, that MD Anderson study I mentioned earlier, a very small group, but this strikes me as something that would be low risk to implement and potentially beneficial. So something that I've certainly started to integrate into my own practice and counseling. All right, and I will draw that to a close. Thank you so much for staying with me and for your time today.
Thank you so much, Dr. Tsai. We are going to move to our Q&A portion now. So if anyone has any questions, please put them in the Q&A in the chat, but I will ask a few that we received ahead of tonight's session. First, I want to say that was a tall order, a tall task to go through all that you went through. So thank you for doing that in the short time that we had tonight. I'm sure it left people with a lot of good thoughts and questions and excitement from what came out of ASCO. So you talked a little bit about brain metastases, but I wanted to ask from this question that we received, are there specific therapies that you would suggest for someone with brain metastases?
Yeah, thank you for asking that question. I think even though there was, I didn't spend that much time on it, certainly it remains a melanoma patient population of concern. Sometimes these can be among our sickest patients. So certainly when we're thinking about melanoma that's traveled to the brain, I think certainly myself, and I think almost all of my colleagues would agree that we try to be as aggressive as possible with our treatments within reason. Definitely a multidisciplinary discussion, depending on the clinical situation, always important to involve my colleagues in radiation oncology, neurosurgery, obviously medical oncology as well. I think in medical oncology, given past trials and work that's been done, the default would likely be aggressive combination immunotherapy with nivolumab plus ipilimumab. But I think relevant to this session with ASCO updates, there's also been some interesting data come out of a trial called Blue Bonnet. And if you'll recall the treatment that I mentioned during this talk as well, with nivolumab plus relatlimab, so PD-1 plus LAG-3 inhibition, that there's been some kind of initial promising data in how that combination might work in patients with brain metastases as well. So stay tuned for that. I know that the Blue Bonnet trial they're still accruing, so certainly look forward to updates from that in the near future.
That's great. Well, thank you. I will ask one more question that we have here, and you kind of answered it, but as a medical oncologist and a patient comes to you, how do you make the best decision on the care that they should receive and the treatment that they should undergo?
Gosh, that's the $1,000,000 question, right? Yeah, such a good question. And every patient is different, right? Every patient is different. Their circumstances are different. Their melanoma biology may be different. We haven't even kind of delved into the role of various things like melanoma subtype and molecular considerations. But all of that factors into things, right? I think having as much correlative data and understanding of the melanoma, for example, comprehensive genomic profiling, are there things we can learn about other, biomarker type data that might help us decide on the best treatment regimen? Where has the melanoma spread? We've already talked a little bit about kind of what might be involved in the calculation for how best to treat a brain metastasis melanoma patient versus non-brain metastasis. So yeah, that's a long-winded answer of saying there's maybe just not one cookie cutter way to approach each case.
So as to say, each case is really personalized.
Yeah, I mean, I think given existing data, there are certainly things that are maybe generally true. For example, thinking about the role of ipi-nivo in the case of melanoma brain metastasis. So yeah, there are certain, I guess, I hesitate to say truths, that's probably not the right word, but certain standard treatments that we could apply to certain situations. But again, back to the patient, right? Are there things that I'm concerned about that might affect how that treatment would work in that patient? For example, immunosuppressed state. Do they have a history of an organ transplant, or do they have a history of an autoimmune disorder? So lots of potential variables there.
Absolutely. Well, thank you for answering these questions and for sharing with all of us the key takeaways from ASCO 2025. On to see what happens this year and what we can bring back to the patient community next year from all that the research world has learned over the years. So I want to thank everyone for joining us this evening. A special thank you to Dr. Tsai for presenting during this Ask the Expert. We appreciate all you do for the melanoma community and appreciate you taking the additional time to be with us today. Again, this program will be on our YouTube channel in just a few short weeks. And then when you close this program tonight, there will be a short evaluation that will pop up in your browser. So please do fill that out and visit melanoma.org to learn about any of our upcoming webinars. And I know that my colleague Caroline put in the chat, we do have a uveal melanoma ASCO 2025 recap as well coming at the end of July. So check out the chat for the registration link for that Dr. Tsai mentioned as well. If you have any questions that you think about later, please do email us at education@melanoma.org. I'll say that again, education@melanoma.org. Thank you everyone for joining us, and we will see you soon.